Welcome, everyone. My name is Jacqueline. I'm co-chair of the Ontario Public Health Association's Alcohol Workgroup, along with Amy Lang. In partnership with CAPE, we are pleased to host today's webinar, Reducing Alcohol Harm in Ontario Municipalities, Policy Options and Overcoming Challenges. Just to give you a little background about both organizations, CAPE stands for Canadian Alcohol Policy Evaluation and is an ongoing research project that provides rigorous assessments of alcohol policies at the provincial, territorial, and federal levels. The Ontario Public Health Association has been around since 1949, and our alcohol work group's purpose is to strengthen the voice around alcohol-related policy to support population well-being. And now I'm going to send it off to John Atkinson to do our land acknowledgement. Thank you, John.
Thank you, Jacqueline. My name is John Atkinson, and I'm the Executive Director of the Ontario Public Health Association. So I am joining you today from OPHA's headquarters, which is situated on the traditional territories of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississaugas. The land is covered by the Dish with One Spoon Wampum Belt Covenant, which was an agreement between the Haudenosaunee and the Anishinaabe to share and care for the resources around the Great Lakes. We further acknowledge that the land is covered by the Between the Lakes Purchase from 1792, which was an agreement between the Crown and the Mississaugas of the Credit First Nation. My family are settlers and moved here in 1972 from Barbados, where they had been settlers since the 1600s. As settlers and as an organization, we are grateful to meet here and acknowledge the contributions of First Nations, Métis, and Inuit people in strengthening our communities and country, and thank all the generations of people who have taken care of this land. While OPHA has taken some steps along the path of reconciliation, there is more that we can and should do in the future. We're committed to moving forward with Indigenous people in the spirit of respect and reconciliation as outlined in the Truth and Reconciliation Commission report. Thank you.
Thanks so much, John. And now just for a little bit of housekeeping. So today's webinar includes a presentation along with a question and answer period, in total about 90 minutes. The presentation segment will be recorded, but the Q&A will not. Links to the recording and webinar slides will be emailed and posted to the CAPE COP website. We invite your feedback about today's session, and a survey link will be shared in the chat box and via email. Regarding stipends for persons with lived and living experience, if you did not already indicate this on your membership form, please send an email, and you can find the email on the current website. And sorry, lost my track there. And you only need to let them know once since they track attendance. If you're joining us via phone today, please email to let them know but just because your attendance doesn't come up automatically. Please note the views and opinions expressed as part of these presentations are those of the speakers. They do not necessarily represent those of our funders or the organizations acknowledged. So I'll be doing the Q&A segment of today's event. Please use the chat box to submit a question at any time, either privately or to everyone. I'll do my best to address these questions during the Q&A period at the end. I will read them all out loud, and you may also use the raise your hand function so that you can pose your question verbally. If you experience any technical difficulties, please message us in the chat or click ask for help. And next slide, please. I'd like to briefly introduce our speakers for today's session. I'm going to introduce them all at once, and then their presentations will take place one after the other. So first, I'd like to welcome Justin Thielman, who is an epidemiologist lead in the Health Promotion, Chronic Disease and Injury Prevention Department at Public Health Ontario, PHO, where he has worked for the past 10 years. During this time, he has led a number of projects examining the determinants of chronic diseases. Recently, he was a co-lead on the burden of health conditions attributable to smoking and alcohol, a report by PHO and Ontario Health. Tim Stockwell was appointed director of the Canadian Institute for Substance Use Research, CSIR, and a professor in the Department of Psychology at the University of Victoria in 2004. He has published over 400 research papers, book chapters, and monographs, plus several books on prevention and treatment issues. His research interests include prevention of alcohol and other drug-related harm, alcohol and other drug policy, measurement of alcohol consumption and related harms, public health and safety impacts of substance use, alcohol harm reduction, and regulatory policies to reduce alcohol-related harm. Next is Daniel Myron, who is a public health and preventative medicine physician and a health services researcher. His research involves using health administrative data with ICES to examine the population-level burden of substance use on health. A focus of the research is examining the health impact of alcohol and cannabis policy and identifying potential disparities. Dr. Myron is a practicing family physician with an interest in addiction medicine. And we also have Melissa Hutchinson, who is a manager with the Durham Region Health Department and has worked in public health for 23 years. Her current area of focus includes substance use prevention with a specific focus on alcohol, opioids, and harm reduction. Melissa holds a master's in nursing from the University of Toronto. And last but not least, we have Alex Swirsky, who is an epidemiologist with the Durham Region Health Department. She primarily works on projects related to healthy neighborhoods, health equity, safe water, and healthy environments. Alex holds a Bachelor of Science in Microbiology and a Master's of Science in Epidemiology from the University of Guelph, where she is also currently completing her PhD in epidemiology. So now I'm going to hand it off to Justin to get us started off with the first presentation. Thank you.
Thanks, Jacqueline. Just want to check if everyone can hear me. Can? Great. So in my section, I'm going to go over some estimates of alcohol consumption and alcohol attributable harms in Ontario. But first, I want to mention Canada's updated alcohol guidance. And at the beginning of this year, the Canadian Centre on Substance Use and Addiction released new drinking guidelines. You may have heard about this or seen these already. And these new guidelines emphasize that any amount of alcohol consumption increases the risk of health harms. And the risk increases the more you drink. So it still has different categories of risk. So low risk, no risk is 0 drinks, because every bit of drinking carries some risk. And then low risk is more than 0, but less than 2. Moderate risk would be 3 to 6 drinks per week. And then high risk would be 7 or more. And then the risk would increase as you go up from 7. Next slide, please. Most of the estimates I'll talk about are from a joint report that Public Health Ontario and Ontario Health did that came out earlier this year. And in this report, we looked at drinking prevalence and the prevalence of different alcohol attributable harms across Ontario and in each of the 34 local public health units in Ontario. And so the alcohol attributable harms estimates are estimates of how many harms, and the 3 harms that we looked at were deaths, hospitalizations, and emergency department visits. How many of those were caused by alcohol consumption? And we calculated these alcohol attributable harms within 9 different categories that were based on different health conditions. We did this for all of Ontario and for each of Ontario's public health units. Next slide, please. So this graph shows the prevalence of people who reported current drinking as reported in the 2015 to 2017 Canadian Community Health Survey. And current drinking is defined as having 1 or more drinks in the past 12 months. So looking at all of Ontario, 77% of people in Ontario age 15 and older reported current drinking. And looking across the different health units, the prevalence of current drinking ranged from a low of 63%, which looking at the graph, you can see that that's Peel, to a high of 83%. Next slide, please. This graph shows the prevalence of exceeding that 2 drink per week threshold considered low risk in the new guidelines. So during that same 2015 to 2017 period, 33% of people in Ontario aged 19 and older reported having more than 2 drinks in the past week. And then looking across the different health units, this ranged from 24% up to 43%. And so these estimates are actually lower than I would have thought. And I think the reason is due to some of the limitations with self-reported survey data. So people tend to underreport the amount of alcohol that they consume. And not only that, but people who consume large quantities of alcohol may be less likely to even respond to the survey in the first place, creating a selection bias. Next slide, please. And here we have the prevalence of binge drinking, also known as heavy drinking. And this is defined as having 5 or more drinks during one occasion for males, or 4 or more drinks for females, at least once a month in the past 12 months. And 19% of people in Ontario aged 15 and older reported binge drinking. And the prevalence of binge drinking ranged from a low of 13% to a high of 28% across the health units. Next slide, please. Here are some estimates of the alcohol attributable harms that I mentioned earlier. And so we have the 3 different types of harms: deaths, hospitalizations, emergency department visits. And so these numbers you see here are for all of Ontario. But in the report that I mentioned a few slides ago, we have similar estimates for each of the 34 health units. And so here you can see in an average year during the 5-year time span that we looked at, 4,330 deaths attributable to alcohol, representing 4.3% of all deaths in Ontario. There were 22,000 hospitalizations, which was 2.1% of all hospitalizations, and almost 200,000 emergency department visits, or 3.7% of all ED visits in Ontario. One thing I actually want to point out with the harms estimates is we're counting both conditions that are fully attributable to alcohol, which would include things like alcohol-induced pancreatitis or alcoholic psychosis. So they're 100% due to alcohol, no other cause. We also include conditions that are partially attributable to alcohol. So conditions like colorectal cancer, hypertension, alcohol is one of the causes, a contributor, but they're not 100% attributable to alcohol. And so we've incorporated relative risk estimates based on systematic literature reviews of the relationship between alcohol consumption and all of these different health outcomes. I'll also mention that unlike those prevalence estimates that we looked at in the earlier slides, these we are tried to adjust for the self-reporting biases by using alcohol sales data. And we'll go to the next slide, please. And here, this table shows the number of alcohol attributable harms split into the 9 different categories based on groupings of health conditions. So again, we have deaths, hospitalizations, ED visits. Looking at the first row, out of the total of 4,330 estimated annual deaths attributable to alcohol, 1,204 were due to cancer, 934 due to cardiovascular disease, and so on. And looking across that first row, you can see that cancer has the highest number. So cancer deaths represent the highest burden out of these 9 categories shown. But then looking at hospitalizations, the second row, you can see that neuropsychiatric conditions actually has the highest number, represents the greatest burden out of the conditions shown. And so neuropsychiatric conditions would include things like alcoholic psychosis, alcohol dependence, and epilepsy. And then looking at ED visits, the highest number is for unintentional injuries, which would be things like accidental poisoning, falls, etc. You may also notice some negative numbers in the table, and negative numbers indicate protective effect. So this means that the estimated number of harms that were prevented by alcohol consumption annually. So if you look at hospitalizations and cardiovascular disease, our estimates show that 2,263 cardiovascular disease hospitalizations were prevented. These would have been ischemic heart disease and ischemic stroke. And I'll just point out again that these estimates incorporate relative risk estimates from recent systematic reviews. But one thing I wanted to note is that the literature continues to evolve rapidly, especially with respect to hospitalizations and cardiovascular disease. So there were a number of recent studies have actually called into question protective effects shown in earlier studies of alcohol consumption and cardiovascular disease. So our estimates are based on, do not incorporate some of the most recent studies that do call this into question. Next slide, please. Okay, this table is just to show a comparison between different sources of harm. So we have the alcohol estimates on the right column, summed up into, this is a 3-year time period. We have smoking in the middle, and then COVID-19, the first column, which, of course, that's been all over the news for years, and of course has created a huge burden, a lot of harms. But looking at alcohol, it's almost on par with COVID in terms of like the number of deaths, number of hospitalizations. So just to give a sense of how burdensome the alcohol attributable harms are across Ontario. And next slide, please. Okay, so the alcohol harms data that I talked about in the earlier slides, it only went up to 2019. But I wanted to point out another tool at Public Health Ontario called Snapshots, which includes data up to 2021. There are a number of alcohol harms snapshots, although I want to point out that the alcohol attributable harm snapshots are only looking at fully attributable conditions. So they're not looking at the partially attributable conditions that are not 100% attributable to alcohol. So the estimates will be different from the estimates in the report that I just talked about. And then one last tool that I wanted to mention, Ontario Health's Prevention System Quality Index, or PSQI, includes a section on alcohol, which includes a number of alcohol-related indicators. The 2023 PSQI focused on health equity, and so looked at alcohol consumption by household income quintile, for example. And the PSQI also includes a number of policy indicators. So for the alcohol section, these examples of these would be minimum alcohol pricing and alcohol outlet density. And that is my last slide. So I think now I'm turning it over to Tim.
Thank you, Justin. Good afternoon, most of you, I think. I'm talking to you from Victoria. So I was asked, next slide, please, to address 3 questions. There's a bit of overlap, I'm afraid, with what Justin's been talking about, so I'll try and go fast. The organisers asked me to talk about the economic and health costs of alcohol in Ontario and Canada, talk about why alcohol policies to reduce harms are important, and to comment on the experience I had as I have to say, a failed expert witness in the Ontario 7-Eleven liquor licensing applications for about, I think there were about 4 or 5 sites a year to 18 months ago. And in each case, my evidence was, I was given the credit of being expert, which is kind of nice, but they completely disregard any advice. So that won't take very long, but I'll mention that at the end. So next slide. So a little bit about why alcohol policy matters in Ontario. Well, you're all here and you probably know all this. It's just a summary. It's one of the standard snapshots we give for each province and territory. In the CAPE project, the Canadian Alcohol Policy Evaluation, when you adjust for underreporting, and Justin was just referencing that, each adult or person aged 15 plus consumes on average 457 standard drinks per year. That was for 2021. Now, these estimates of harms here are substantially about 50% higher, 40% higher than Justin's. It may be there's a difference in the year that we applied. We looked at 2020, which was peak consumption during COVID. Famously, per capita consumption went up about 8% across Canada during COVID. We may also have inputted different assumptions about cardiovascular disease and whether alcohol prevents it or not, but we need a side discussion about that. It's substantial. Also, we've got some estimates that allow for the estimates of the prevalence of drinking above guidelines and binge drinking, published in the Canadian Journal of Public Health earlier this year, which make adjustments for underreporting. And they're also substantially higher in most cases than the estimates Justin was just providing. So they're all pretty shocking and high. So, you know, the bottom line is there's a lot to be concerned about. Then the alcohol deficit. So if the Canadian Substance Use Costs and Harms Study estimates that the economic costs of alcohol is for Ontario is over 7 billion, whereas revenue from across government, sales taxes, markups from the government alcohol monopoly is just over 5 billion. And so it's pretty much the deficit for alcohol is nearly $2 billion. Next slide, please. So just mention there's the website for the Canadian Costs and Harms, the Costs and Harms from Substance Use in Canada report recently produced that gives estimates for all provinces and territories for all years from 2007 to 2020. In that most recent year, it's almost $50 billion, $49.1 billion of costs across substance use. And I'm going to show some breakdowns by different substances. Next slide, please, comparing alcohol with other substances. So we have 8 categories of substance. The major ones, obviously, alcohol, tobacco, cannabis, opioids, but a lot of other substances as well. If you could go to the next slide. This is the overall breakdown by category of cost, healthcare, lost productivity due to premature mortality or absenteeism and so forth, criminal justice costs and other direct. You'll see that most of the costs are in lost productivity, then healthcare closely followed by criminal justice related costs. And Ontario, that's for the whole of Canada, but it's pretty representative for Ontario as well. Next slide. And then how this is broken down by substance, you'll see that, well, actually 40% of the total costs of substance use can be put at the door of alcohol, and over 60% of alcohol and tobacco in combination. Opioids comes in third, quite a long way behind. Next slide, please. And some trends which I think are important, showing that alcohol is the leading cause year by year from 2007, but increasing in the level of per capita costs compared with tobacco in brown, which has been declining. The light blue one, the third one, opioids, has clearly been increasing. And if you looked at hospitalizations as well, just again referencing Justin's slides, we actually have, I think in every province, alcohol attributable hospitalizations exceeding those from tobacco. And our estimates are that they have matched in terms of deaths and hospitalizations, those from COVID. Next slide, please. So in terms of responding to this, effective alcohol policies, by and large, are those that reduce per capita alcohol consumption. There's a well-known principle here that if you look at the total consumption of a population in any developed country, the greatest proportion of it is consumed by the heaviest drinkers. So something like 10% of drinkers are consuming 50% of all the alcohol consumption. So policies that reduce total consumption are fairly well targeted at heavier drinkers. And you can see as a result of that reduced morbidity and mortality when per capita consumption decreases. Next slide, please. This is an illustration of how that idea that as per capita consumption goes up or down, life expectancy goes in the opposite direction. Now, forgive me showing a slide of Russian data. I just think it's pretty eloquent. You just have to look at it, and you can see when alcohol consumption is high, life expectancy is reduced. Pretty dramatic stuff from Russia. Well, of course, a lot of dramatic things occur, but it illustrates the point well. Next slide. So the World Health Organization, in its global alcohol strategy, has recommended 5 best buys using the acronym SAFER: strengthening availability restrictions, advancing drink driving countermeasures, facilitating screening, brief intervention and referral, enforcing bans on advertising, marketing, raising prices through tax and minimum unit prices. They aren't in order of evidence for effectiveness. If we look at the next slide, this shows the 11 categories of intervention we assess in CAPE, and they're listed in order of the size of the impact and the scope. That we weight each of these dimensions in terms of the evidence of effectiveness multiplied by their likely scope of effectiveness across the population. So everyone who drinks pretty much is influenced more or less by pricing and taxation and availability, and the control system. So I've indicated by star those areas where the literature shows evidence of direct effectiveness. The arrows, these signify areas where, by and large, these kinds of interventions or strategies facilitate the directly effective ones. So health and safety messaging or warning labels, for example, is a good example. There is some evidence now of direct effectiveness on consumption and related harm, but by and large, the importance of them is we know that they raise level of support for pricing strategies, availability restrictions, and the others. Because if people aren't aware of the harms, don't believe in them, and most Canadians aren't aware of the alcohol cancer connection, for example, they won't support these policies. So next slide, please. I haven't got much time. I'm going to focus just a little bit on pricing and taxation as the single way ahead of the others in terms of effectiveness and feasibility. Minimum unit pricing of alcohol, famously introduced in Scotland after a 6-year legal battle through all the courts in Europe and the UK, putting a floor price of 50 pence for a small unit of ethanol, 8 grams of ethanol. This was an idea that they got from us in Canada early on in the process. The Scottish researchers contacted us and asked, how do you do it in Canada? How's minimum pricing done in Canada? And we said, I said, do not do it like we do in Canada. You need to attach it to a unit of alcohol or a standard drink of alcohol, because we have the same minimum price for a week as strong beverages. 2% beer or a 20% strength beer has the same minimum price rate in most jurisdictions. Anyway, it was introduced in 2018. Next slide. Even published in the British Medical Journal, as soon apparent it was working like it was supposed to do. So see, the top figure shows after the introduction, the price per gram of alcohol shot up, and the amount correspondingly purchased shot downwards. So in terms of impacts on consumption, that was clear. Very quickly, next slide, it was evident there were impacts on harms. So in the first year, a fall of 10% in alcohol attributable deaths, or actually deaths specifically caused by alcohol. The evaluation published this year after, I guess, 4 years of implementation estimated a 13% reduction in all alcohol attributable deaths in comparison with England, which didn't have minimum unit pricing. So taking account of the control area, very clear reductions in harm. And incidentally, those reductions were most significant and substantial in low income regions. So it appears that minimum pricing is also a strategy for reducing health inequalities. Next slide, please. So some of the evidence from Canada, it's a little older, but it's minimum pricing, however crudely done, has been shown to reduce consumption, alcohol attributable deaths and hospitalizations, and in some studies, alcohol attributable crime, and there's a lot of publications on that from our group. Next slide, please. in terms of taxation, there's a beautiful systematic review by Alex Wagner, you can find, which just looks not only impacts on consumption, I mean, by and large, across all the studies, if you get a 10% increase in price or tax, you get a 5% reduction in consumption. But the evidence on harm is the most eloquent, and this is a nice analysis from Alaska, and it simply shows that rates of alcohol-related deaths just shot down every time there was a tax increase. And there's an overall gradually increasing trend because these are just total numbers, raw numbers in this slide, they're not rates. But each time the tax goes up, the deaths go down, and then the value of the tax increase erodes with inflation. Next slide. So in terms of how Ontario is scored in the CAPE project, we had a seminar on this, you probably find it online, won't go into great depths, but I'm afraid overall it's a failing grade. And unfortunately, the most important domains of pricing, availability, the alcohol control system even have got failing grades, but there's some, Ontario is very good at lots of things. There's some excellent policies and strategies in impaired driving and liquor law enforcement, screening and brief intervention, and very good at counting the harms and reporting on what's going on, as Justin just illustrated. But overall, the policy implementation is weak, and there's a huge opportunity and potential for improvement and further harm reduction. Next slide. So this is my last slide, and I guess I've already said this. I mean, the 7-Eleven, I think, applied for about 60 liquor licenses across Ontario. I believe Alberta 7-Eleven has already got permission to sell alcohol in their little 7-Eleven corner stores. It was a huge precedent that was set, and the Ontario Public Service Employees Union hired me as an expert witness, and they contested the application in several several sites in different cities in Ontario. And sadly, I failed to convince the presiding authority judge to rule against the application. I essentially focused on the concern about the precedent and the Canadian and international literature, which I've kind of alluded to here on the risks of increased availability. But because I wasn't a local person, clearly from the other side of the country and not even born in Canada, and my research was general, it wasn't specific to each neighborhood, that it was just ruled as irrelevant, and the applications were granted. But I think that's a nice segue, because I think you're about to hear how if you've got local researchers doing fantastic local research with local data, you can get different outcomes. So I'm going to, the next slide, just sign off there. And if you want to visit our CISA's website, you can see lots of information about CSUCH and CAPE and all of these other studies on pricing and so forth. Thank you very much.
Should I start?
Yes, please feel free to go ahead.
Okay, so I apologize. I'm at a different conference, which I need to run to at 1:50. So I'm very sincerely sorry, but thanks for the invitation. I'm going to chat with you today about two studies that I've led, looking at the association between alcohol access and healthcare visits to alcohol in Ontario. So next slide. And my name's Daniel. I'm a family physician and researcher, and I use big data or big health data to look at drug and alcohol harms and the impact of policy. So, as we just got a wonderful introduction or background in those prior presentations on the burden of alcohol on the health system, we've published previously, and again, we can see that the alcohol-related healthcare visits are rapidly increasing in Ontario. As Tim very nicely summarized, restricting the physical availability of alcohol stores is considered one of the most effective population-level alcohol control policies. There's increasing interest about whether there's emerging data about how alcohol taxation has different impacts on men and women and by socioeconomic status or position. And there's interest in whether different types of alcohol policies have a similar variation. And I think that, again, as we have a discussion about alcohol availability, there are ongoing debates about how causal this association is. So it's certainly true that there is increased alcohol availability in areas where people drink more and where people experience harm. And that's been very robustly established, but the directionality of that is less clear. I think, whether or not alcohol retail stores open in response to high levels of use and consequent harms, or whether the retail stores cause people to drink more as well is less clear. There's probably some evidence for both of this. Okay, next slide. So I would just highlight, and I think it was done nicely, but alcohol-related visits are increasing in Ontario, and they have very clearly accelerated during the COVID-19 pandemic. Here's a study that we published where, if you look at the bottom part of the figure, this is rates of outpatient visits due to alcohol, emergency room visits due to alcohol, and hospitalizations due to alcohol, and how they changed during the pandemic. In the study, we looked at whether it differed for people who had never had treatment for an alcohol use disorder or people who had treatment for an alcohol use disorder. Some caveats there about who that's capturing, but we saw that during the COVID-19 pandemic, there was close to a 30% increase in outpatient visits related to alcohol. Emergency room visits declined slightly, but if you contextualize that by the fact that emergency room visits for all causes really decreased, they increased as a proportion, and then hospitalizations went up by 6 or 7%. So certainly visits were increasing pre-pandemic, and they may have accelerated during the pandemic. Next slide. I think probably why there's lots of interest in this discussion is because in the next couple of weeks, we are probably going to see substantial changes to how alcohol is sold in Ontario. It's been in the news recently. Some of the discussions have been about removing caps on the number of stores. So we might go from around 2,500 stores to north of 10,000 stores, discussions about taking away some of the pricing controls, discussions about reducing the role of the LCBO or provincial monopoly. And all of this is happening because there was a 10-year agreement between the government of Ontario and the beer store, who was responsible for much of the beer sales and distribution, and that is coming to an end, and it opens up the possibility to change things. And again, I think probably before the holidays begin, we will get a very good sense of what those changes might look like. Next slide. And so I'm going to walk you through a study that we haven't published yet, but have been working on. And the idea was to examine the association between alcohol access and healthcare visits attributable to alcohol in Ontario, and to look at whether this differs for people with or without a history of treatment for alcohol use disorder. And we're going to very briefly touch on some prior work that examined the impact of introducing alcohol sales in grocery stores in December of 2015 in Ontario. So next slide. So in the study, we're using, it's a population-based study, so it captures all healthcare visits in Ontario that's accessed through ICS. And we're going to look at the quarterly rates of two sets of outcomes. So every, 4 times a year between 2013 and 2019, for just under 500 different geographic regions, we got the number of visits that occurred for the number of people that were there. And we looked at ED visits and outpatient visits that were attributable to alcohol. And then what we did is that in each one of those quarters, we got access to a list of all the alcohol retailers who sold takeaway alcohol. So again, beer stores, LCBOs, wine stores. And we determined for each one of the geographic regions how much access they had to the 7 closest alcohol outlets. And then we identified in each one of these geographic regions the number of people who had in the past 2 years received care for an alcohol use disorder or an alcohol-related visit. And then we did a series of regression models to look at the association. And we'll look at the next slide. So, the study includes, every year, it includes just over 10 million people, of whom 1.7% have received outpatient hospital or emergency room based care for an alcohol related cause, and most people haven't. Keep in mind that this is capturing people who've received outpatient care or hospital based care through the formal health system. It's excluding people who might have accessed treatment through non-government covered services, so private counseling, some addiction services. So this is a pretty conservative estimate, but at least 1.7% of people have had some variety of physician-based treatment for alcohol use in any given year in Ontario. And we'll go to the next slide. And I think the high level things to take away from here is that over this study between 2013 and 2019, we had just under 500,000 emergency room visits fully attributable to alcohol, and just over 500,000 outpatient visits for alcohol use disorder or an alcohol-induced psychosis. And we see that individuals who have previously been treated for or previously received care for an alcohol use disorder actually incur 2/3 of those visits. So if we look over on the far right column, we see that 290,000 of those 437,000 happen in people with an alcohol use disorder. We'll pop over to the next slide now. So this is what our model spat out, and I'll walk you through it. It's a bit of a busy figure, but we essentially, so remember, we're comparing around 450 geographic regions in the province. At multiple time points, we know what kind of alcohol availability they have. And we've turned that into 10% or decile changes. So essentially we say, if you live or in regions that have the top 10% of alcohol access, you can then compare them to lower levels of alcohol access. So if we look at the top left graph, for example, the reference is the people sitting in the bottom 10% of alcohol access. And as you move along, this is the risk that occurs that's adjusted for differences in age and sex and immigration status and population density and a variety of other factors that might explain different patterns of alcohol use and harms. But the model's showing a pretty clear dose-response relationship where the more alcohol access you have in the region that you live in, the higher the rates of emergency room visits related to alcohol or outpatient visits related to alcohol. And if you compare the top 10% to the bottom 10%, they're just under 50% higher. And then we looked at whether this relationship was the same for people who had prior treatment for alcohol-related causes or no prior treatment for alcohol-related causes. And we found that for emergency room visits, which is the bottom right graph, there's no difference. It's a similar association the whole way down. Whether or not you've had treatment in the past, it seems like the more alcohol access that there is in the community that you live in, the higher the rates of harms. And in the top right graph, we see that maybe there's a difference for outpatient visits related to alcohol. So it seems as though members of the population who have not previously been treated by a physician for alcohol may have a greater susceptibility to increased alcohol availability. And I would take those findings, we can interpret them a couple of ways. It could be that it's a true association and that, people who have previous treatment for an alcohol use disorder or have an active alcohol use disorder are less susceptible to the nudge effects or to the changes when you have greater alcohol availability that they have, and you can imagine how if you drink a sufficient amount that you'll enter withdrawal if you don't drink, whether or not alcohol sales are close to your home or there's, 1 store, 2 stores, or 5 stores may not influence your drinking patterns as much as someone who has less of a dependence for alcohol and may be more susceptible to nudge factors or convenience factors. The alternative explanation is this could be related to the way we've defined outpatient visits. But I think the takeaway that I would have here is, again, it's a pretty robust and local data suggesting that as you see more and more alcohol availability in regions of Ontario, you see higher rates of harms. We'll go to the next slide. And I just summarized this on the previous one, but a reiteration of what's been seen in numerous international settings and before in some Canadian settings, but certainly here in Ontario, we see a similar relationship where greater alcohol availability is associated with greater healthcare visits related to alcohol. And we're going to do some ongoing work looking at more causally at the impact of greater alcohol access. Go to the next slide. This is just a graph of how alcohol retail has expanded between 2013 and 2022 in Ontario. In 2015, alcohol was allowed to be introduced in grocery stores, and it went from something like 50 stores in 2015 who got a license to 450 by 2022. And there's also been an expansion of what are now called LCBO convenience outlets, and were previously the agency store. But we see that the stores have kind of capped off at just above 2,000, and these are stores that sell alcohol for takeaway consumption. And again, I think in the next, we're shortly going to learn how many, but there's probably about to be a very large expansion of the number of stores selling alcohol. We'll go to the next slide. Just as a teaser, we previously published some work comparing regions of Ontario that got a grocery store selling alcohol to regions of Ontario that didn't. And our modeled estimate was that receiving a grocery store selling alcohol increased rates of emergency room visits due to alcohol by 6%. And there are several other important explanations for this finding, which we're doing in follow-up work right now. But that's kind of some of the available evidence that we have that maybe that, and again, this was limited to the first round of grocery stores selling alcohol in their opening, but maybe it increased rates of ED visits due to alcohol by 6% in those regions. Next slide. So, from a policy perspective, alcohol access has greatly expanded over the past decade in Ontario. It's about to substantially go more. There's going to be lots more stores. They're going to be increasingly privately operated. They may be able to sell spirits when previously they've been restricted from that. And I think the whole body of evidence is suggesting that we may be in store for increases alcohol use and harms here in Ontario. And I think that there really does need to be a greater emphasis and attention to some of these public health concerns. And next slide. And just a big thank you to all sorts of members of the team and sponsors. And I'm so sorry, but I have to run. If anyone has questions for me, please reach out by email or get in touch, and I'd be happy to hear from you.
Thanks so much.
Thanks, Jacqueline. Before I proceed, I'll just do a quick check. Can you hear me okay?
Yeah, we're good.
Wonderful, thanks. Hi, everyone. Good afternoon. My name is Melissa Hutchinson. I'm a manager at Durham Region Health Department. I'm also pleased to introduce my co-presenter and colleague, Alex Worthy, who is an epidemiologist at Durham Region Health Department. So today we're going to share some information about our experience in partnering with a local municipality to limit alcohol retail availability through the use of local socio-demographic and health data. Next slide, please. So just a bit about Durham Region. To get started, Durham Region is a regional municipality with a population of over 740,000. It's situated just beyond Toronto's eastern border in Ontario, and Durham Region has 8 municipalities, including the city of Oshawa, which is the largest by population size. Within our region, public health services, which aim to keep people healthy, prevent injury, illness, and preventable deaths and premature deaths, is carried out by Durham Region Health Department, which is mandated by the Ontario Ministry of Health. Next slide, please. So as mentioned a little earlier in this presentation, in Ontario, the 7-Eleven convenience store chain received provincial approval to sell beer, wine, and coolers for on-site consumption at more than 50 stores. There are currently 60 7-Eleven stores in Ontario, and motorists routinely stop there for fuel, and children regularly visit for snacks, candies, and drinks. In 2022, the City of Oshawa asked Durham Region Health Department staff for assistance with preparing for a licensed appeal tribunal to oppose granting the 7-Eleven convenience store a license to sell and consume liquor within a specified location in one of our priority neighborhoods. Next slide, please. Thank you. So Durham Region Health department provided support in two different ways. First off, we provided some scientific evidence. So we accumulated extensive scientific literature to support the submission. And secondly, we provided local context using our health neighborhoods data. And both Alex and I will go into these areas in more detail throughout the presentation. Next slide, please. So to begin, we'll look at the scientific evidence that we provided. So to support the tribunal, we submitted an extensive list of high quality scientific evidence, which clearly illustrated how alcohol is a major contributor to the global burden of disease, disability, and death, effective alcohol policies that protect public health, the impact that physical availability has on alcohol use and alcohol-related harms, and the impact that retail density and availability has on violence and overall community vitality. Next slide, please. I'll now pass it over to Alex, who will share more about our local data.
Thanks, Melissa. Okay, so the second key component of the information provided by the health department to the city of Oshawa was local data, which indicated why granting the 7-Eleven liquor license in this location was not in the best interest of the community. And as Melissa said, these local data were based on the health department's health neighborhoods. So the image on the right is actually a screen capture of one of our health neighborhoods dashboards, and this is specifically for the Durham region profile. So what are the health neighborhoods? As we all know and seen documented throughout the COVID-19 pandemic, health and well-being are affected by a person's living conditions, including the physical, social, and economic characteristics of where they're born, live, work, and age. Given these social and ecological determinants of health can vary substantially within a community, Durham Region Health Department created the health neighborhoods to better understand health and well-being across Durham Region at a finer geographic level. These health neighborhoods were created by dividing the region into 50 smaller community boundaries. And although these areas are larger than what you would think of when you think of a neighborhood, they were created at a size large enough to allow us to present health information accurately. Currently, we present data regarding 96 sociodemographic and health indicators for each neighborhood, along with comparisons to Durham Region. And when the data are available, we also compare to Ontario. Next slide, please. So indicators of socioeconomic resources, health and well-being vary substantially across Durham's 50 health neighborhoods, highlighting noticeable inequities in how Durham Region residents experience health and wellness. So in 2015, Durham Region Health Department identified 7 priority neighborhoods that require focus to build on health and well-being. These neighborhoods have the lowest income in Durham Region and rank poorly in terms of educational attainment and high unemployment rates. They also have substantially greater health challenges compared to the other 43 health neighborhoods. Approximately 1 in 6 Durham residents live in a priority neighborhood, and 5 of the 7 priority neighborhoods identified are in the city of Oshawa. Next slide, please. So the area that the 7-Eleven in question is located in is actually a priority neighborhood. So when we gave local context to the city of Oshawa, the first thing we provided was information about why this neighborhood was identified as a priority neighborhood to start with, including sociodemographic indicators and measures of health inequities. So examples of data for this would be that this neighborhood rates significantly worse on all 6 socioeconomic resource indicators related to income, education, and employment. For example, about 40% of children under the age of 6 live in low-income households in this neighborhood compared to the Durham average of 13%. Also, life expectancy, self-rated health, and self-rated mental health are significantly lower in this neighborhood compared to Durham. We also provided a number of maps, and the purpose of these was to show the distribution of points of interest or areas that may be vulnerable or at risk to negative impacts if this 7-Eleven were to be granted a liquor license. So in the 2 maps, the location of the 7-Eleven is highlighted by the little red triangle. The map on the top shows points of interest. So these are things like childcare centers, community facilities, and social housing complexes. And as you can see by the map and the dots around it, it actually has quite a high density of these locations. And this is one of the reasons why granting this liquor license would not be in the best interest of this community. And then the map at the bottom shows the 7 elementary and high schools that are in very close proximity to this 7-Eleven location. Next slide, please. So we also provided emergency and healthcare service utilization data. So things like paramedic calls, police calls, emergency and doctors visit rates for mental health and addictions within this particular neighborhood. Examples of some of the data would be that emergency department visits for assaults in ages 10 to 24, emergency department visits for motor vehicle collisions in ages 15 to 24, and police reported domestic incidents, including those with children present, have significantly higher rates in this neighborhood compared to Durham as a whole. We also provided health indicators for this particular neighborhood, which have been related to increased alcohol use or exacerbated by alcohol use, as described by the first step in Durham Region's literature review that Melissa explained. So just for example, about 1/4 of mothers in this neighborhood are young, so 23 years of age or younger, and babies born to this neighborhood are more likely to be born to mothers who smoke cigarettes or used alcohol or drugs during pregnancy. And the prevalence of several chronic diseases, including diabetes, hypertension, COPD, and cardiovascular disease, are all significantly higher in this neighborhood compared to Durham. And all of these indicators have been associated with increased alcohol use or exacerbated by alcohol use in the scientific literature. Back to you, Melissa.
Thanks, Alex. So another important aspect that we wanted to share was the fact that a local group of concerned residents worked with Dr. Tim Stockwell, who you heard from earlier today, to submit concerns regarding the proposed location. And namely, they talked about the potential impact on youth exposure, the concerns related to that, and the concerns around community vitality, as this is a priority neighborhood, as Alex mentioned. Next slide, please. Oh, sorry, that's the importance of the community voice. Next slide. Thank you so much. So ahead of the scheduled hearing, the 7-Eleven withdrew their appeal for their liquor license. The municipality's opposition submission, which included local sociodemographic and health data, to illustrate why the 7-Eleven liquor license was not in the best interest of the community, may have helped to prevent expansion of alcohol retail availability in the priority neighborhood. Again, we have no answer that this was a convincing reason why they withdrew their application, but nonetheless, they did withdraw the application, and we do hope our submission helped with that. So that concludes our presentation today, and thank you so much for the opportunity for us to share our experience.